All right. Oops, sorry about that. All right. Welcome to Project Echo. I'm Will Schmeckley, Project Coordinator at Nebraska Medical Association. We've got an interesting talk today. Todd and Alex are discussing GLP-1s and SUD treatment. Just my usual housekeeping things. No financial relationships to disclose. We're a grant-funded project funded by SAMHSA grant that comes to us through Nebraska Department of Health and Human Services. And then the usual process for CME certificates, I will email out a link after the meeting today. I'll also drop that link in the chat if you want to grab it just right before the meeting ends today. You can do it that way too. Just complete a quick survey and then I'll email your certificate within a couple of business days. And I think that's all I got. So I'm going to stop sharing my screen and I will let our Echo panel introduce themselves. I think we're missing a couple right now. Let's see. Mary, would you like to go first?
Good morning. My name is Mary Ellis. I am a nurse practitioner and attorney here in the state of Nebraska.
Thanks, Mary. And John?
Hey, good morning. I'm John Massey, and I'm a pain physician here in Nebraska.
Thanks, John. I think Alex is going first, so Todd, I'll let you introduce yourself next.
Good morning, Todd Stull. I'm a psychiatrist.
Thanks, Todd. And it looks like we don't have Ed or Stephanie yet. I think they may be joining later. So um, I think, Alex, it's all yours.
Thanks, Will. I'm getting my laptop going here. I don't know if do you have the slides set? I think that might be better so that when I have to jump off, Todd can take it from there. Or Todd, if you want to share your screen, if you have the slides up, I should have them in a second here. So Alex Dworak, family physician. We're going to be talking about how to use GLP-1s. A lot of us already know this in primary care. And then I have to go do procedures with my residents because I'm bad at calendars at 8 a.m. And I'll let Todd talk about the addiction aspects of this, which I think is going to be quite interesting. But I wanted to talk about GLP-1s, both in terms of somebody who's using them a lot as a primary care doctor and as somebody who's on them, and just the health benefits they can have, side effects, and how to use them and have things go well. So, thanks, Todd. Okay. Sweet. All right. Todd, if you want to go to our next slide, we collaborated on this. Todd got all my Chaos Muppet energy, so I appreciate him patiently working with me. We want to talk a bit about what GLP-1s are, where and how they work, current indications, emerging indications. They have a lot of side benefits with things like diabetic kidney disease, vascular disease, and metabolic liver disease, especially. Um, yeah, and I'm not getting one on my end. Sorry, Nicole. Will, I don't know if you're seeing anything there. Uh,
I'm not hearing an echo either. It could be your speakers, Nicole. I'm not sure.
okay. My piece of this is going to be talking about nutrition and physical training, and then sarcopenia and frailty prevention. There was initially a lot of concern that we were going to make people skinny and weak and fragile. Costs and access. This is an all day, every day kind of thing for me in terms of how can we get these meds for people who aren't independently wealthy. And then Todd's going to come in with a really interesting piece of this, which is emerging evidence for how GLP-1s work in the brain and can impact alcohol. Next slide. Thanks, Todd. Okay, so just for some background, and Todd put this together, so thanks to him. You can see the developmental history of these meds, and I love asking my residents this. This goes back to a molecule discovered in the venom of the Gila monster in the Southwest. Possibly this helps these lizards go long periods without eating, but again, it led to exenatide, which came out when I was a resident, which is one of the first, or it was the first human med for this. We had a patient who I remember who had heart disease and was wanting to lose weight and had diabetes and was asking for this in hopes of helping them lose weight. And it turned out the patient was onto something. So, next slide. And I'm deliberately trying to go quickly to give Todd a lot of time here. So incretins are gut hormones from the enteroendocrine system, and they work with our beta cells. I explain to patients these support the function of your pancreas, and that's part of why they don't cause hypoglycemia the way insulin does. Insulin just comes in and does its thing, and your sugar's going from here to here. If it was high, it's going to get normal. If it's normal, it's going to get low. These allow your pancreas to remain in charge, and also prolong the time to islet cell burnout and loss of endogenous insulin production capacity, which staves off people getting to that brittle type 2 diabetes where you need basal bolus, but you still have insulin resistance and your sugars are all over the place. And even with intensive management and a highly motivated patient, it sucks. So I am belligerently aggressive in getting my patients with type 2 diabetes on these meds pretty much at the first opportunity and continuing them unless the patient absolutely can't tolerate them, just because these have really revolutionized primary care treatment of diabetes and staving off that burnout of the pancreas, which leads to a really rough situation. So, and then GLP-1 is produced in the small intestine and brain, as Todd has highlighted here. Regulates glucose, promotes satiety, which helps you feel more full, and slows digestion, which basically causes a little bit of gastroparesis. And then GIP is another one that's contained in tirzepatide. And then there's also a glucagon agonist that's coming with retatrutide, which, Todd, I believe you have mentioned later in the slides. So that's probably going to be approved next year. Okay, and then here's some molecular background that, again, Todd put together in a very detailed fashion. I think in the interest of getting through my material and letting him talk about the addiction effects, this is there for your reference. But Todd, if you want to move ahead, I'll jump into my stuff and then clear the floor for you. Okay, so again, we have these receptors in the brain where they work in the hypothalamus, which probably relates to food intake and cravings. I can say personally, I have a lot less ansiedad de comer, is what a lot of my patients will say in Spanish, anxiety to eat, or food noise would be another thing. Again, I can think more consciously about, oh, I should eat or I want to eat before I go to the gym. I'm not just eating mindlessly, and so that's having that helpful effect for me. And then these are present in the brain's reward and pleasure systems, which Todd will talk about with their effects on substance use. And then they increase nutrient uptake in muscles. So I will touch a bit more on that, but they probably improve muscle quality, actually, which is interesting. Again, they slow digestion, basically induce a little bit of gastroparesis. And then these suppress glucose production and have a lot of benefit in metabolic liver disease. And then in the pancreas, again, stimulating insulin secretion and then reducing glucagon. And this allows the pancreas to work more effectively and slows the burnout from overwork of islet cells. Okay, next slide. Okay. And then Todd highlighted some of the neurological pathways in which these affect the pleasure circuits. They don't make you stop enjoying your life. I can say that. It's not just like everything's gray and there's no color in life or anything. I mean, it really is kind of subtle, but I've definitely noticed it. And then in terms of anorexigenic effects, they also have some effects with some different things involving dopamine there. And then they promote satiety, as we've said. Again, I don't find myself going back for seconds or thirds near as much anymore. It's a lot easier to have portion control and, again, just be more mindful and more cognitively thinking about it instead of emotionally thinking about it. And then you don't need these in the central nervous system to have glycemic control, where they'll help in the portal circulation. But Todd had found that you do need these in the brain to have weight loss. So, which is interesting. So. Okay, and then here we're getting into some of these renal and cardiac things that we mentioned. They can help with blood pressure control. There's some studies that are looking at anti-inflammatory effects, including there's in the ADA guidance evidence and a recommendation that these things can help with osteoarthritis of the knee. And that's not just indirectly through weight loss. There are studies that I've seen that are not, they're still ongoing. This isn't proven yet. they're injecting GLP-1 molecules directly into the knee instead of like a corticosteroid. So there's maybe a direct effect in the tissues, not just helping people lose weight. And then these medicines are part of goal-directed medical therapy for cardiac disease now. Again, if somebody's had heart disease, a heart event, we should be trying to get them on these medicines if at all possible. I know our employer-sponsored insurance annoyingly says that the cardiologist has to prescribe it, which is dumb because cardiology would prefer us to do that. But again, that highlights that there are demonstrated benefits for people with heart failure and atherosclerotic cardiovascular disease. And then kidney protection, these are, again, part of goal-directed medical therapy for diabetic kidney disease. And we have to have a reason for people not to be on them to get, is basically my opinion. So. Okay. And then again, these started off as diabetes treatments, but I agree with what Todd has here. These are really foundational for weight management and cardiometabolic risk reduction. And then again, obesity, cardiovascular disease risk reduction, diabetic kidney disease, metabolic liver disease, and possibly we're going to get to where there's enough evidence base for substance use too. We have multiple therapies, and again, I have a slide talking about okay, great, these things are awesome, but my patient can't afford $450 a month. What do we do? And as we mentioned before, retatrutide is a triple agonist, whereas tirzepatide is a dual agonist. Retatrutide is going to be coming on the market, and up to 40% weight loss can be achieved for people who do well with them, which again is about the same as metabolic weight loss surgery. Which, interestingly, when I talked to Corey McBride at a recent NMA function, she highlighted that at first we didn't know why bariatric surgery did what it does, but we knew it worked, so we were wrong to deny it to people. The current evidence is that it probably works on these hormones, more so than like changing the volume of the stomach. So I guess that tracks that retatrutide would be close to that. So. Here's the list of all the meds. I think most of us are already aware of these. Exenatide, I don't know if Bydureon is even still on the market. So the current ones we talk about are the semaglutides, tirzepatides. Liraglutide is still a reasonable option. It's a daily injection, so it's less convenient, but it can be attainable at FQHCs at least. Dulaglutide has a medication assistance program, and so that's one I reach for a lot. It's off-label for weight loss, but I mean, the evidence is there. And then orforglipron is the new pill version. This does not have as many of the other indications because it's newer for like diabetic kidney disease and metabolic liver disease. But it is a daily pill that, unlike the oral semaglutide, you don't have to take it rigidly around food. And so, somebody who has a disability or struggles with their schedule, this could be a great option. So, okay. And then, so a lot of them are just GLP-1 single molecular target. Tirzepatide is a dual agonist, and again, this for a lot of people may have fewer GI side effects, and it does promote more weight loss and has a higher top end dose. There's also some data on improving muscle quality, which is why I chose that for myself. Retatrutide, I know a couple of people at my gym who are already taking this as gray market peptides from China. Not a great idea, obviously, but this is in phase 3 trials and will probably be approved next year. And again, it really seems to be next level in terms of its potential for weight loss. So, and then there's another investigational one there that Todd mentioned too. Okay, good. And then I'm here, the FDA-approved indications, which are narrow. There's a lot more that these medicines are good for but again, we're going to focus on mostly the alcohol and addiction possibilities here when Todd takes over. So. And if people have questions, feel free to put them in the chats. If you're wondering about anything that I talk about, including some of the things that I decided not to write into as much detail because I didn't want to take up Todd's time, please get a hold of Will, email me. Happy to give my sources. So this is directly from a March 2026 update from the ADA and gets to more of what I wanted to focus on to set the table for Todd, which is how do we use these safely. If someone has rapid weight loss from any cause, but including from these meds, we do need to worry about micronutrient deficiencies. And I've put in bold the ones we can screen for. I have actually found a patient of mine who has different reasons to be on Vyvanse and a GLP-1. and wasn't he's in poverty and has a lot of stress and wasn't paying a lot of attention to his nutrition. He had vitamin C deficiency, aka scurvy. He has extraordinary medical complexity, and he just hadn't mentioned it. But when we screened him and I put him on vitamin C, he was like, "Yeah, my gums were bleeding and my teeth were starting to feel a bit loose, and that got better." And I was like, "Boy, am I glad we screened you." So I've screened several people now. That's the most striking one I've found. But again, I usually am like multivitamin, or you could eat a salad. Uh, those of us on GLP ones, I think a multivitamin is a good idea. And then there's that link to the ADA's citation. Okay, and so if you want to think about who should we be looking at, just in general, BMI over 30 or excess abdominal circumference, which is actually a more helpful thing, but more difficult to do and not as automated in the system. And if if they have a BMI of 27 and a weight-related comorbidity, that's also a consideration. There's still some official guidance that people of Southeast Asian ancestry, including from the Indian subcontinent, should be considered with lower thresholds of 23 and 27, if I recall correctly. We should always individualize it and talk to your patient. People who we should think about beyond those kind of narrow indications just for weight loss. Again, my eminence-based opinion is if you have type 2 diabetes, you need these medicines unless you absolutely can't handle them. They just help that much. And again, I would prescribe an unlimited number of these meds to prevent one burnt out type 2 pancreas that's blood sugar's just all over the place and they're in the hospital with the hypo and having complications and this really takes over their life. So obstructive sleep apnea, tirzepatide's approved for moderate to severe sleep apnea. People with type 1 diabetes and obesity, which does happen, can use these. That has been studied and you don't have to, like you can go for these meds for them. ASCVD, CKD, especially diabetic CKD. And again, as I mentioned, knee osteoarthritis and obesity. As Todd's going to talk about, if you can't get it just for this in terms of insurance approval, but if they have alcohol use disorder and obesity, and especially any of these other things, this is a really intriguing thing to look at. Okay, so again, in terms of side effects, most of us know this if we're using these in clinic. A lot of them are GI, so start low, go slow, check in with your patients. Fiber is a good idea. You can use some Imodium if they have diarrhea. People may need Miralax if they get constipated, and then smaller, more frequent meals and avoiding high-fat foods. Protein supplements, very good idea. They are liquid foods that don't have a lot of sugar will help you hit your protein goals without typically causing as many side effects. So, and then rapid weight loss of any cause is a risk factor for gallstones. So if someone's having abdominal pain, consider that, and that may be a reason. That could be one of the reasons why we might need to go away from this, or somebody might need a gallbladder surgery. But a lot of people need those anyway. And if they have a lot of other reasons, I think that's not a risk that should keep you from considering these meds. Although again, stop and reevaluate if needed. And then hypoglycemia almost never happens with these. Risk goes up significantly if people are on a sulfonylurea or insulin. I hate sulfonylureas and try as hard as I can to get patients off them. In addition to the chance of hypo, there's long been thought in the endocrine circles that these burn out the pancreas faster by stressing your islet cells. That's the opposite of what we want to do. I already try to get people off sulfonylureas. They're cheap. They're a pill, so patients may like them. They're widely available in Mexico and Central America, which I see a lot. But again, I think I try to get them away if they're not on a GLP-1. If they are on one, then the sulfonylurea's got to go. So, and then the lean mass reduction. Again, this is more nuanced than we think. People need to lift and they need to supplement with protein. You can get a DEXA, but again, that can be confounded. So, if somebody's elderly or has chronic kidney disease, you want to make sure that they're not vomiting and getting hypovolemic. That's a good idea anyway. Okay, so nutrition, people need to be paying attention to this. You can get malnourished if you're losing weight, especially rapidly from any cause. It would be lovely to have everybody see a registered dietitian. That is not the world we live in. People can do some internet reading and general guidelines, 1 to 2 to 1.6 grams of protein per kilo of body weight. Should that be actual or ideal? But again, unless somebody already has severe kidney disease, you can go over your protein a little bit and you'll be fine. As I've highlighted, protein bars and protein shakes are a good idea. The shakes, as non-solid foods, may cause less nausea, and that is important. Ask me how I know. Fruits and vegetables, especially vegetables, although again, if they have a lot of fiber, that can be a large like gut bolus. So again, people need to learn what works for them. Fiber again can be helpful. If you, as we've mentioned, you want to consider a multivitamin and make sure that people are not just stopping eating. You generally want to focus on 1 to 2 pounds of weight lost per week. Any faster than that, for reasons we don't have time to get into, is unhelpful. So. Okay, so if somebody has a true allergy in terms of like, again, a lot of people should be on this unless we have a good reason not to. Here's some good reasons. People can have an allergic reaction with either injection site, or one of my elderly patients who also had some other autoimmune diseases had to be hospitalized because of some pulmonary symptoms. This is quite rare. I offered her referral to allergy and immunology. She decided to hold off. She didn't want to take a chance on that, trialing another one that was going to go from semaglutide to tirzepatide for her. And then multiple endocrine neoplasia syndrome or history of medullary thyroid cancer. If someone's had papillary thyroid cancer, which is far more common, that's not something we have to avoid these meds for. And then the patient just doesn't tolerate it. Some patients who don't do well with the weekly injections, if I can get them on daily liraglutide, which is more of a hassle, but like it's not as big of a slug of medicine because it's a smaller dose every day, and you can start off very gently. Some of my patients will tolerate that, and others just it doesn't work. But I feel I need to try as hard as I can to get them access to all these benefits. And then if somebody is known to be sarcopenic or frail, you'd want to be careful with that. Occasionally, I've had an elderly patient who has lost more weight than we'd like, and I've put them on a bit of insulin, which is an anabolic hormone, to help them kind of get back up. If they are elderly, I'm a little bit less aggressive. A little bit of nutritional reserve is a good thing in geriatrics. And then if somebody has known gastroparesis from, say, diabetes, you can cautiously try this, but just expect that it's going to be rough and lots of informed consent from the patient. But for the glycemic control benefits and all the other benefits, they if they give informed consent and watch carefully, it's not like it can be worth trying. Okay. And then pancreatitis is brought up a lot. The short answer from this Cleveland Clinic article is probably we can, again, with careful informed consent, proceed. This highlighted that in people with type 2 diabetes, and if it has hypertriglyceridemia, which is itself a risk factor for pancreatitis, so these people are already kind of a setup. People on GLP-1s had less pancreatitis going forward than people with diabetes who weren't on GLP-1s. So, again, I think this is a very interesting article, and again, it can be considered. So, and then again, if the rapid weight loss an independent risk factor. So basically, if and also if they've had pancreatitis and it was due to alcohol or an ERCP or something, this isn't that. But you need a lot of informed consent, but you can choose to carefully go forward. And I feel like you've got good literature to back you up. But again, these medicines have such profound benefits. If somebody tolerates them, I really think you should try hard to get patients access to them with proper counseling, and if the patient's game for it, obviously. Okay, so, and then this touches here, reversing metabolic liver disease. That's a big deal. And again, we shouldn't limit their use and deny patients these benefits just because they've had pancreatitis. If they get it again, again, talk to a GI doc if you can. But it's not like, oh, they've had pancreatitis. Nope, can't even think about it. So, all right. And then Todd put this together. People can get a little bit of increase in their heart rate. My heart rate variability has gone down a tiny bit being on them. But people can also get some blood pressure reduction. If they're already orthostatic or have diabetic autonomic neuropathy, you'd want to be careful. But again, the shared decision-making, informed consent, these medicines really can be very helpful. So I wouldn't say that's a reason to completely avoid it. Okay, and then this is really where I wanted to highlight. So obviously people should train. We should all train whether we're on these meds or not. The American College of Sports Medicine recommendations are there. If somebody only has time and energy for one and they're on GLP-1, I would say prioritize strength training. You get some cardiovascular benefits from GLP-1s, as we've seen. We worry about muscle loss and frailty as a possibility. And strength training, I think, should be the first place to go. Not everybody has access to a gym, whether for safety reasons, cost, time, preference. So the best training, again, is what will our patient actually do. My recommendation is again, pretty straightforward. Compound movements involving the large muscle groups, moving across, multiple joints bending, moving the most weight possible. So a barbell back squat or a deadlift versus like a reverse wrist curl with like the pink dumbbells. Those would be the opposite ends of the spectrum of like helpful for this purpose because it's a big stimulus, not useless but close. And if we and train ourselves, it's easier for us to talk to patients about this. As always, I think if I'm telling a patient to do something and I'm not doing it, why am I not doing that? So I would encourage us to reflect on that when we can. And if you're already training, awesome, good job, keep that up. It's going to help you age well and give a lot of benefits. People can use barbells, dumbbells, kettlebells are my preferred option if somebody doesn't have a gym or doesn't want to go out to a public gym for whatever reason. They're small, they have a ton of versatility. They're cheap relative to buying a squat rack, a barbell, and plates. And there's a lot of helpful things on YouTube with a not too bad learning curve for the movements with them. An adjustable dumbbell set would be another thing that could work that gives you a lot of flexibility. And then a strongman sandbag, you can just buy it and fill it with sand. That's pretty functional. And again, you can do a lot with a sandbag or two. And then if somebody has mobility limitations, a muscle imbalance or weakness or a surgical history, if you can get into PT, a good PT will plan and help them like learn how to train and then take off and do that on their own. So, and then in terms of sarcopenia, to wrap up so Todd can get going, uh, a lot of this, and I have citations, as I mentioned, comes from Barbell Medicine. It's a great podcast run by two doctors who also actually lift. The short answer is we don't need to be as worried as we thought we did. Muscle quality seems to improve. So intramuscular fat decreases and the muscle cross-sectional area may go down, but it's because the muscles got less marbling in it. If you think about like a steak, the muscle fibers are not degrading in quantity or quality. We see less sarcopenic obesity if you're on a GLP-1 than if you're not. Grip strength stays the same if people are on these meds. Again, if somebody can't or won't lift, and I have patients who have just told me that's not going to happen, I think you should still give them the benefits of these medicines. I strongly recommend. But again, we're probably safer with these than the original buzz was. And then in terms of, okay, these meds are cool, great. Alex and Todd, you've convinced me. How do I get them? Here's the self-pay options. And then if you have an FQHC or happen to work at one, liraglutide can be got for $30 a month under the 340B federal discount program. Dulaglutide does have this medication assistance program, and you can use obesity, diabetes, liver disease. Again, you don't need a SOCH, which is relevant if you take care of people who don't have Social Security numbers. And then if somebody has Medicare, the bridge program is convoluted, but it eventually will happen. I have a family member who's on them through that. And then this is going to keep changing and evolving. And when Chat comes on the market, it'll go even crazier. I've had to pay attention to this, and I think my days of doing that are coming to a middle. So. All right, and then speaking of strongman sandbags, I'll do this and then let Todd take over. Since we're talking about mental health and substance use and training, on the 29th, here in a couple of weeks, I'm putting on a lifting competition with all proceeds going to benefit mental health and substance use services at the underserved FQHC that I work at. If you are in Omaha and can make it out, I hired a bagpiper from Omaha Pipes and Drums. We're gonna have a food truck, some breakfast treats. We've got Scottish Highland Games cabers, a couple of tractors from the Antique Tractor Club that was very good to my autistic brother when he was younger, like a bunch of strong humans doing crazy stuff. So, and again, all the money's going back to some of the stuff we're talking about here. All right. Todd, I think it's to you, and I'm going to go do some surgeries with my residents. Thanks so much for giving me the floor and running the slides for me too, so I can jump off and not torpedo the Zoom here.
Thank you very much. I'm sorry you had to rush through this. So you brought up some really kind of important points. And before we move into kind of the second part of this, I want to emphasize not only kind of the mind-body connection, but in essence, let's go a little deeper, and that is the effect of the endocrine system and metabolic problems have strong kind of interactions and effects with uh, especially mental health or psychiatric illnesses. And so, people that have, for example, diabetes are more prone to having mental health problems such as depression. And we take it on the surface, but it's actually much more detailed than that. It's not just because they have that. Yes, it may be a psychologically difficult, but there's things that are happening from a physiological aspect that are making things different. When you talk about addiction, and I want to have a few comments here, we're doing better within the realm of addiction for um, not glossing over the big overlooks kind of addictive substance, which affects more people than anyone, and that's nicotine. We have still a long ways to go, but it's one of those things that's often overlooked. Well, within the analogous realm of physical and overlapping mental health problems, the thing that's overlooked, and Alex talked about it or mentioned it and so on, but it really, I think, needs to be at the forefront of what we're doing, and that is movement. Movement includes not only strength training, but aerobic and anaerobic kinds of things, and mobility and strength through mobility. We know that skeletal muscle is a big kind of user of glucose and mobilizing glucose. So people that are inactive don't activate the glucose transporters that are in skeletal muscle, which is not only a big deal, but as we age, if we lose muscle, we set ourselves up for more problems. So um, not only healthy aging is correlated with uh, oxygen delivery to muscles measured by VO2 max, but it's also strongly correlated with strength, especially lower extremity strength. And I've lived in this world a long time because I've done a lot with sports. And so for 30 years, this is a real comfort area for me to talk about. Loss of strength in the lower extremities is a major detriment for kind of developing other medical problems, not only in the lower extremities, but mobility about the hips and the ankles and the toes. People that lose toe strength are more prone to fall and break a hip after the age of 65, and a third of those people are not alive after a year. So we need to be talking about not just putting somebody on medicines. In fact, I'm glad that we're revisiting kind of the medicine thing because people, in my opinion, are often on too many psychotropic medications without a clear indication or benefit, or we're chasing our tail, if you will, to treat side effects, and there's limited benefits. So relationships are important to help with emotional well-being, but so is physical kind of activity, if you will, movement. So I want to say that because it has an effect on what we're talking about with the GLP-1s and the issue with lipids and overweight kinds of problems. And so please don't overlook that. Now let's move into the emerging roles of the GLP-1 agonists. And incidentally, the GLP-1s there's studies coming out um, all the time with different kind of indications or uses. And so it's if somebody has found additional studies in addition to what I put up in this slide deck, I wouldn't be surprised at all because there's so many that are coming out right now. In general, you start with kind of obstructive or diabetes and obesity or overweight and um, then obstructive sleep apnea and so on as some of the indications. We're now, gee, we're finding out they have effects on kind of liver function and helping preserve liver function. And oh, by the way, there's neurodegenerative kind of effects that been shown in some studies with, and this is a summary slide here. We'll get into a little more detail with Parkinson's disease and Alzheimer's dementia. There seems to be effects within schizophrenia, for example, at least treating some of the metabolic problems that go with it, and specifically with some of the medications that are causing problems with weight gain and the metabolic syndrome. But there's also seems to be some effect with depression. I'll show you a couple studies on that, and even with eating disorders. And then we're going to cover the three substances here: alcohol, opioid, and tobacco. So um, I can't get into all the detail. There's emerging roles in various aspects of overall health. So what happens in the nervous system? The GLP-1s are found throughout the nervous system, and they're involved in not only development of nerve cells, but differentiation and resiliency or neuroplasticity, and then protection of the neurons. And remember, there's two main cells that are in the nervous system: the neurons and the glial cells. And so the GLP-1s decrease the pro-inflammatory effects of cytokines and, in essence, let glial cells, microglia, which is, there's many types of glial cells, astrocytes and oligodendrocytes and so on. Microglia are kind of the street cleaners and have anti-inflammatory effects and really let them kind of go to work. They also decrease the accumulation of alpha-synuclein. Well, that's in your synucleinopathies, such as Lewy body dementia and Parkinson's dementia, but they reduce the formation of plaques and tangles, which are found in Alzheimer's. So that we're seeing widespread effects within the nervous system, not only protection and development, but formation of kind of processes that reduce inflammation. We also know that GLP-1 agonists are in the nervous system, and they have an effect on modulating dopamine release. And you've heard me say before, we go to kind of a reductionistic model when it comes to looking at neurocircuitry with dopamine. Dopamine has a role. There's a whole bunch of other things that take place within that mesolimbic rewards center, and specifically in the midbrain and the medial and lateral ventral tegmental area that have projections to the now I feel good nucleus accumbens. The habenula is an interesting nucleus, and I want to bring it up because it's overlooked. It's above the thalamus. It's a part of the epithalamus, and it's a connector that has a lot of GLP-1 receptors, and so it's connected through the IPN, or the interpeduncular nucleus, to the forebrain, and this area attenuates the response of dopamine projections and some of the other projections. In other words, what the habenula, if you activate it, it turns down the intensity of the reward that's a part of the mesolimbic system, so that reward system. And it also has implications, pretty strong implications in mood regulation. And so remember, mood and substance are strongly related. And so, or to think of it differently, psychiatric problems are often comorbid with substance problems and vice versa. So there's a lot of activity that's going on. It's not just ventral tegmental area, nucleus accumbens, into the amygdala and hippocampus and so on. There's a whole bunch of other processes that can have an effect on reward and pain in that area as well. And, we talk about this being addiction and pain. So reduced dopamine release takes place using a GLP-1 related to nicotine, and there's nicotine kind of components again within the medial habenula and the interpeduncular nucleus. So I realize that's detailed. I get it, but I want to leave you with the point that it's not just ventral tegmental area that's having effect here. GLP-1 agonist reduces liver metabolism by producing toxic metabolites that actually decreases, I'm sorry, the toxic metabolites which protect the liver. GLP-1s slow the metabolism of alcohol, and so alcohol levels go higher so you think, okay, well, gee, if the alcohol levels go higher, they're going to be more toxic. But again, these GLP-1 agonists decrease the production of the toxic metabolites. So there's a protection effect. So in essence, not only you're using various components of metabolizing alcohol, including the microenzyme system and alcohol and acetaldehyde dehydrogenase, but it's slowing the metabolism. Blood alcohol levels go lower. Um, the toxin metabolites go lower, and people feel like that they handle alcohol differently and they tend not to drink as much. This is also found when a study here, and you'll see the references at the end for those that are interested. Some are included in the slides, but you'll see that there's a attenuated kind of MRI response in the ventral striatum. Well, the striatum is a part of the, in essence, basal ganglia and reward area. And so we know that there are not only functional changes that we can see on an MRI, but people report clinical changes. And so exenatide was the first study that came out, looked at the 127 patients that were getting 2 milligrams sub-Q weekly for 26 weeks, and it reduced heavy drinking. That's the bottom line. It's like unexpectedly and alcohol intake in individuals that had a BMI over 30. So how did we get here, right? How did we get here? Well, let's back up a step here because I think this is really important this I don't believe has been shared on an echo, and I've kind of thought about saying it, but I want to say it now. When you talk about medicines that are used to treat alcohol use disorder, and the big three we talk about are acamprosate and naltrexone and disulfiram, which is Antabuse. Let's talk about the ones that are used most commonly, and that's acamprosate and naltrexone. Number needed to treat to reduce heavy drinking is about 12 patients. That's not very good when you think about it. Number needed to treat in terms of abstinence goes up. It's about 18 patients. Let's put that into comparison to buprenorphine or methadone. When you talk about number needed to treat to retain in treatment, which is a key element for opioid use disorder, it's about 2 to 3 patients with both methadone and buprenorphine. How about when you're talking about buprenorphine and methadone, what's the number needed to treat to stop using? And that's about 3 to 4 people roughly. So that's not quite as good, but it's still considerably better than naltrexone or acamprosate for alcohol reduced. If you want to reduce mortality or think about number needed to treat for mortality, okay, in opioid use disorder, methadone does better than buprenorphine. So the bottom line is, if you compare, let's just take methadone and buprenorphine. How many people do you need to treat to kind of have an effect? It's about 2 to 3 with them. How many do you need for naltrexone or acamprosate? It's about 11 or 12. So now we all of a sudden, and Topamax is certainly equivalent to naltrexone. So now we're into oh, gee, we don't have the greatest treatments for alcohol use disorder, quite frankly. And what are these GLP-1s going to do for us? And the bottom line is over time, we don't know. Here is another study, 14,000 veterans who were taking GLP-1s. Their audit scores, if you're familiar with audit, is basically a screen to see if somebody has problematic drinking. The audit scores reduced. And problematic drinking reduced. And again, this was in Journal of Clinical Investigation for those of you that want to read the details of it. Here's GLP-1s in 48 in a JAMA article found that low dose semaglutide reduced the amount of alcohol compared to placebo and especially heavy drinking, but it did not affect the average number of drinks per day or over time. A second study here looked at 80,000 plus patients that had obesity and were on semaglutide, and there was roughly a 50% lower risk of first incidence of alcohol use compared to other anti-obesity medicines when they're comparing the two. In other words, what I'm saying is those that are taking a GLP-1 compared to traditional or other types of anti-obesity medicines, the GLP-1s had an effect on alcohol. Here we're looking at semaglutide and liraglutide lowering the risk of hospitalization. And although the reductions were not quite as robust as naltrexone and disulfiram, there still was an effect of the basically 230,000 people that were studied in Sweden. So again, there's another effect, a potential another option here. Let's get into a little more detail of comparing studies here and the potential role of GLP-1 in substance use in a systematic review, looking at alcohol and then smoking and some other studies with alcohol as a secondary indicator. This Clausen study at the top we looked at over already, or I mentioned, it decreased heavy drinking days. Okay. The Hendershot study of semaglutide using 0.25 to a milligram showed decreased kind of amount of alcohol, but was inconsistent with heavy drinking. Story's still not out, right? When you look at the Probst study, it was looking at smoking and secondary effect of alcohol use and found that there was decreased alcohol intake. When you look at the Langsford's study and looking at smokers, one of the big concerns of smokers is, am I going to gain weight? And people, it may be a relapse trigger, and there was definitely less weight gain in this group, and the A1C, hemoglobin A1C levels improved. The final study with exenatide extended release 2 milligram Yamin study showed increased, this is in smokers, showed increased abstinence rate, and it actually had an effect on withdrawal symptoms. But remember, all kind of addictive substances use the same neurocircuitry in our brain, with the exception of the serotonergic hallucinogens like LSD. So when you talk about association of semaglutide and tobacco use in patients with type 2, here's another study that basically said it reduced smoking and the need for prescription medications for smoking. And this took place in patients with and without obesity. So again, effects on tobacco use and another kind of thought besides the things we're using for tobacco use, which varenicline and Wellbutrin and nortriptyline and so on that are being used sometimes. So how about opiates? Let's change gears. And I know I'm going pretty fast here, but there's a lot to cover in a short amount of time, and you can review this and the details if you want over time. How about opiates? Here is basically 5 studies. The first was a small randomized controlled trial. So, again, very small, but it seemed to reduce cravings over a 3-week period by about 40%. Here's a big study that's retrospective of 500,000 patients or 500 plus shows a 40% reduction in opioid overdose with prescriptions. That one's, worth probably remembering because that's always a concern with people that are using opiates. Another retrospective study that was a Medicare study showed that there was a 36% reduction for opioid use disorder in type 2 diabetics who had opioid use disorder. Um, and so hospitalizations went down. A VA study looked at veterans with type 2 diabetes and pre-existing substance use and found there was a 25% reduction in incidence of opioid use disorder. And then the final one showed a reduction in overdoses, final study, which was retrospective. So again, these are not the most robust studies, but it's mounting evidence. And so that's what I'm trying to show here. How about GLP-1s and the risk of substance use disorders in veterans with type 2? This is an interesting study that's somewhat complicated, and they're looking at GLP-1 and seeing if there's a reduction in the risk of use of alcohol, marijuana, cocaine, nicotine, and opiates or other substance. And there was two protocols. One protocol had protocol one had no history of a substance use disorder, and so they had lower risk. And then they had protocol two. These are individuals that had a pre-existing substance use disorder. So they divided these protocol one and protocol two into two different trials. Trial one and protocol one are individuals that were either on a GLP-1 agent or a traditional sodium glucose transporter. Okay, so that's trial one of the primary trial, if you will, or of the protocol one. Protocol two, these are the individuals that had pre-existing substance use disorder. And again, they were put on either a GLP-1 or a sodium glucose transporter. And again, we're looking for the outcomes for these two groups. Again, one has prior existing substance use and one does not. And each group was put on either a GLP-1 or a sodium glucose transporter inhibitor. And we're looking at outcomes for how much alcohol or what's going on with alcohol, marijuana, cocaine, nicotine, opiates, and so on. When you look at the results here, the groups, either one, protocol one or two, that were on a GLP-1 had reduced risk of developing a substance use disorder or reduced risk of adverse outcomes in people that had a pre-existing problem. So in other words, the group that was not on the sodium, the SGLT inhibitors, um, they didn't do near as well as the group that were on the GLP-1 inhibitors, regardless of whether that group had a no substance use disorder or had a pre-existing. And so, and this is across all the substances that we're talking about. So it reduced the risk of developing an alcohol problem, a marijuana problem, a cocaine problem, nicotine, opioid, and so on. All right, for my last couple slides here, I'm going to shift gears and because there's been obviously discussion around psychiatric effects. And I mentioned that one of the main things to consider when someone is on a medicine that um, causes metabolic syndrome, weight gain, elevated sugars, and change in lipids, if you will, from medication. There may be a role for GLP-1s. Well, beyond that, there's a systematic review of emerging evidence to look at GLP-1 agonists associated with depression, suicide, eating disorder, and substance problems and schizophrenia. And basically, um, there's moderate in this group and studying, there's moderate antidepressant effects and potential roles for modulating individuals that have eating problems and substance problems, which you've heard me talk about. Schizophrenia, not so much treatment of the illness, but again, the metabolic effects that I mentioned. And so that's clearly something to think about. Although the challenge is without an FDA indication, people are having to pay the price, even if there's a medication assisted program or use of GoodRx. How about this study looking at semaglutide and effort-based decision-making in depression. Remember that depression, it really has three major components: the psychological components, I'm sad, I have anhedonia. Then there's the physical components, sleep problems, eating problems, change in sex drive, and so on. And then there's the cognitive component of depression. Gee, my brain doesn't work as well. I feel like I have brain fog. It's harder for me to process information or remember things or make decisions and so on. And what this study found after 16 weeks in this double-blind, placebo-controlled study with a fixed dose of semaglutide is that motivation improved. And so that's affecting, some of kind of what patients who have depression experience. The effort to get things done when you're depressed is sometimes feels overwhelming or almost insurmountable. So there was an effect in this study looking at or demonstrating motivation. Um, I thought I had two slides, I guess. Yeah, those are the last two. So that's uh, that's the um overview of substance problems. And I recognize that's a whirlwind through things. If you're interested, please review the slides. All the references um, are there. There is a reference page, and you can get into more detail. I chose to go kind of a broad brushing as opposed to a lot of details, mainly because we don't have FDA indications, and mainly to stimulate your thinking around, gee, patients for alcohol use haven't responded to uh, the traditional treatments. What other options do I have? Or they have comorbidity with diabetes or weight issues or obstructive sleep apnea and substance problems. Uh, let's pay attention to kind of how they're doing if we put them on a GLP-1. So that's where we're at for today in terms of the overview. Thanks for your attention today.
Hey, thanks so much, Todd. I did drop a link to the valuation survey in the meeting chat. If you want to grab that, I'll also be emailing that out in the next hour or two. Let's see, in a couple of weeks, John is up with discussing some updates on buprenorphine for pain. So hope to see everyone then, and we will end it there. Have a great Friday, everybody. And Echo team, if you want to jump over to another link for a quick team meeting for whoever's able to do that, we'll do that real quick. Thanks.